Okay, so in the previous video, we talked about unipolar depression. We talked about how unipolar depression manifests. And one of the exclusionary criteria for unipolar depression is that you cannot have any history of a manic episode. Because if a person has a history of a manic episode, then the appropriate diagnosis is bipolar disorder. Now, so when we talk about the term manic episode, it's also important to understand what we mean. A manic episode is a period of elevated mood that lasts for 7 days or longer. We do have something called a hypomanic episode, which lasts for 4 to 6 days. So there are these gradations. In order to have bipolar 1, a person must have the full manic episode. In order to have bipolar 2, the person must have at least a hypomanic episode. Now, I bring that up because we haven't even talked about the depressive piece, right, for bipolar. So you might ask yourself, well, why is it if a person has a single manic episode, they have no history with depression, why are we diagnosing them with bipolar disorder? And the answer is simple. We expect longitudinally that things will shift, right? So there will be eventually that depressive crash. So anytime there is a manic episode, it is a form of bipolar disorder. Okay. So what does bipolar disorder look like in general, right? You might have periods of elevated mood, expansive mood, irritable mood, but usually you also have periods of depression as well. Whether we're talking about bipolar 1 or bipolar 2, you still are going to have a full depressive episode, right? So even though we specified manic or hypomanic episode on one end, the depressive episode still has to be a full 2 weeks. Okay. So symptoms include restlessness, agitation, sleeplessness, pressured speech, flight of ideas, sexual disinhibition, grandiosity or inflated self-esteem, and impulsive or reckless behavior. Now, what's interesting is if I put a column for depression and a column for manic symptoms, whatever is listed as overexcitement would be underexcitement. Whatever is listed as restlessness would be excessive sleeplessness or excessive sleeping, right? High agitation, low agitation, pressured speech, reduced speech content, right? So we can compare the two extremes. Now, there are different subtypes in the DSM, and we have to determine whether a person has a manic episode, a hypomanic episode, a mixed episode, which is exactly as it sounds, combination of the two. So we will specify what the diagnosis is, what the subtype is. So when we look at bipolar disorder, there are lifelong estimates anywhere between 0.4% to 1.2%. This is relatively low, but the numbers are low because we're talking about childhood. If we were to look at the rates as we go across the lifespan, the rates do increase a little bit. All right. Now, in terms of younger people, we see milder versions of bipolar 2, which, again, if you were keeping score, bipolar 2 doesn't require a full manic episode. A hypomanic episode is sufficient. or cyclothymia, which is a long-term low-grade bipolar disorder. They're more common than bipolar 1. We also see rapid cycling, which means going from your highs to your lows and back, as also pretty common. Now, uh, this was the point I was making. The rates do increase post puberty, and eventually they do get a little bit higher in adulthood. Bipolar disorder affects males and females equally, right? There's no significant difference between males and females as it relates to bipolar disorder, and comorbid conditions include anxiety disorders, ADHD, conduct disorders, substance use. So the peak onset tends to be more mid to later adolescence. So we see 15 to 19 years old. Of notable interest, the rates of bipolar disorder or the peak onset is later than unipolar depression. And that shouldn't shock you that unipolar depression oftentimes shows first, that means. We also see that bipolar disorder is a chronic condition. It is very hard to treat, and there is a poor long-term prognosis. So that means this is going to be a more likely to be a lifelong disorder. So we have to be very careful. And when we talk about impulsivity or disinhibition, it shows up with bipolar disorder in the form of uh, substance abuse. People with bipolar disorder are more likely to abuse drugs. Spending habits, a person can engage in impulsive or reckless spending. You can have um, sex hypersexuality is a common one, and then other kind of like health damaging behavior, risky behavior, like speed racing down the highway or things like that. And I bring this up because these are the reasons why people wind up in treatment is they start to manifest with some of this impulsivity, and we have to figure out where it's coming from, and then ultimately we have to work on it, right? We have to target it. When it comes to spending, I had one client who had bipolar disorder, but when they were manic, they also had psychotic features. So they would not always remember what they did in a manic state. And I had one person in particular who used his credit card to spend and buy a large quantity of merchandise, and he didn't remember it. So after the manic episode subsides, he starts getting packages delivered to his doorstep. And he's like, I didn't order this. He starts seeing charges on his credit card. I didn't make this charge, because he didn't remember. He didn't remember that he actually made the purchases. So he must have spent several $1,000s in a manic episode, and he didn't remember any of it. So obviously his initial reaction was fraud. And then I asked him, well, if there's a charge for a purchase and it was delivered to your house, if someone was trying to use your card for fraud, why would they have it delivered to you? Right? Why would it, you know, that's too much of a coincidence, right? They would likely have it delivered to some random address, and then they would take it from there. They wouldn't have it delivered directly to you. That doesn't seem logical. So he became more aware of some of the dissociative and psychotic features he had when he was in a manic state. So, what causes bipolar disorder? Well, there are very few studies that actually look at what causes bipolar disorder in children and adolescents. We know that there's a genetic vulnerability. So, mood and affective disorders do have a genetic component. We also know that high stress environments can tip the scale a bit. So if you have conflict in the home, if you have fighting between parents, you know, a very stressful environment, these can also induce a risk of in, induce a risk of bipolar disorder. I see in the chat fraudulent gifts. Yeah. Yeah, exactly. Now, when we treat bipolar disorder, we usually use a multimodal approach, right? So we're going to use a combination of psychotherapy with medication. It's usually lithium. Now, lithium as a treatment for bipolar disorder is a very early and old treatment, but it remains a very effective treatment. The one thing that you have to be careful is lithium toxicity. So people who are put on lithium, you do see routine blood draws to make sure that their lithium levels are in range. And then, obviously, in addition to the therapeutic interventions and the medication interventions, particularly because we're working with children, adolescents, we're going to involve the family as well. We're going to try and give them some psychoeducation, explain to them what bipolar disorder looks like, and how to detect a manic state, how to detect when someone's, crashing or going into a depressive state, and the same thing with the patient as well. So that is bipolar disorder. That's a short one. I do have a longer video that I might also share with you because this is kind of like a very cliff note version of bipolar disorder. I think I'm going to share a longer video that I do for my adult psychopathology class. So if you're wanting more, I'm going to give you that video as well.